Amiodarone or lidocaine? What the experts say? Amiodarone and lidocaine are both medications that can be given to treat heart arrhythmias. Over the years, lidocaine and amiodarone were used interchangeably during a cardiac arrest. Current research, however, has shown that amiodarone is more effective in treating arrhythmias and has fewer side effects. Today, lidocaine should only be used to treat arrhythmias during a cardiac arrest if amiodarone is not available. Sudden cardiac arrest is an emergency with a high incidence ranging between 320,000 and 700,000 incidents per year in the United States and Europe. At the hospital, admission is approximately 35 to 40%, while at the hospital, discharge is much lower, 8 to 24%. Importantly, the favorable neurological outcome is reported only in less than half of patients admitted to ICU subsequent to the return of spontaneous circulation. The current guidelines for the treatment of among out-of-hospital cardiac arrest with a shockable rhythm ventricular fibrillation, or pulseless ventricular tachycardia, advise only amiodarone as an antiarrhythmic drug after 3 attempts of defibrillation, while lidocaine may be used alternatively if amiodarone is not available. Furthermore, in a recent randomized controlled trial, however, amiodarone and lidocaine had comparable results, even though the recent randomized controlled trial was perhaps not that prominent. Intriguingly, amiodarone and lidocaine showed a significantly higher number of patients admitted alive to the hospital and a greater survival chance at hospital discharge in the subgroup of patients with bystander-witnessed cardiac arrest. Before this recent randomized controlled trial, a recent meta-analysis analyzed the efficacy of antiarrhythmic drugs in the treatment of cardiac arrest, but it included drugs not currently recommended and suffered from large biases in the studies included. For instance, many of these studies were retrospective chart reviews, with unbalanced baseline characteristics, or different timing of drug administration, and strictly lower dosage treatments. For such limitations to be overcome and in view of the recently published large randomized controlled trial, we conducted a meta-analysis aiming at assessing the efficacy of amiodarone as compared with lidocaine. Although amiodarone and lidocaine are deemed the benchmark of care and are encompassed in present guidelines to support effective defibrillation of shock-refractory and to prevent recurrences, no antiarrhythmic drug prescribed during a cardiac arrest has presented increased chances of survival to hospital discharge. Resuscitation may be used as an alternative if amiodarone is not available. Amiodarone is a membrane-stabilizing antiarrhythmic drug and improves the response to defibrillation in ventricular fibrillation or hemodynamically unstable ventricular tachycardia. The onset of its antifibrillatory action is slow-paced than lidocaine, but its effect is longer-lasting. Events of bradycardia and hypotension post-return of spontaneous circulation have been reported in patients receiving amiodarone during resuscitation. Lidocaine has been one of the antiarrhythmic drugs for shock-resistant or recurrent ventricular fibrillation in the past. Interestingly, lidocaine has detrimental effects on countershock efficacy due to an increase in lidocaine's affinity for sodium channel receptors in an acidotic environment and has been associated with an increased rate of post-shock asystole. Previous evidence on the use of lidocaine versus amiodarone was uncertain, while some authors showed higher chances of survival to hospital admission in patients with shock-resistant ventricular fibrillation when amiodarone was used as compared to lidocaine, other reports were contradictory. Thus, although current guidelines advocate amiodarone as the first-choice drug in refractory and recurrent ventricular fibrillation or pulseless ventricular tachycardia, recent evidence may boil down to potential discussion and revision on the consensus on science. Indeed, similarly to vasopressors during CPR, there is evidence of benefit only on the short-term outcome but not in the long-term survival, meaning that a greater number of patients potentially resuscitated with the aid of an antiarrhythmic drug subsequently died during a hospital stay. Several reasons may provide a potential explanation for this evidence. Among these, the timing of administering the drug has a vital role to play. The suitable time at which these drugs should be given when using a single shock strategy remains unknown, but it is likely that their efficacy is gradually lost with delayed administration, particularly during the course of the so-called metabolic phase, when the ischemic injury causes the release of metabolic factors causing additional injury. The beneficial effects of early intervention are well recognized in the instance of a defibrillation attempt, as well as vasopressors administration during cardiac arrest. For instance, epinephrine has been proved to be effective survival to hospital discharge and survival with a good neurological outcome when given within 10 minutes after passing out, while evidence of probable harm has been recorded when it was administered later. Amiodarone or lidocaine was usually given if ventricular fibrillation or ventricular tachycardia persisted after at least 3 shocks, as mentioned in the clinical studies. Both amiodarone and lidocaine seem beneficial equally with regards to survival to hospital admission. However, neither amiodarone nor lidocaine ameliorates long-term outcomes in terms of survival to hospital discharge or neurological recovery.